anybody's brave enough to move on up, it would make it a little bit more intimate, but we'll do it in either case. So I'm Terry Winter. Hello. And I'm a retired nurse and a health planner, and one of the members of the Healthcare for All Working Group, which is a partnership of North Bay Jobs with Justice and HPEACE, which is the Health Professional Social Justice Organization in Sonoma County. And thank you for coming. So, you know, the focus of our talk is that the healthcare system in our country is a mess. It's a major threat to our lives and to our financial well-being. And in fact, it's not even a system. It is rather healthcare chaos. And I wanted to explore with you why we pay so much for healthcare and get such disappointing results. And what can we learn about how to provide it in a way that serves us better? I got two sets of controls here, so I hope I can keep the slides in sync. So a little review first. We pay twice as much as any other country in the world for healthcare. And yet we leave many of our people uninsured or dangerously underinsured. We spend more on healthcare than all of these other countries combined. What do we get for the money that comes from our pockets? Well, we've often been told that we have the best healthcare system in the world. But is this true? The quality of our care, in fact, is the worst among wealthy countries, and sometimes falls behind that of the third world. We have the highest rate of errors, the most dangerous country in the developed world when it comes to women giving birth, and our system is the least efficient of all wealthy countries. And because you live in a country, in this country, you can expect to die 4 to 8 years before people in most of those other countries. While poor life expectancy has a huge amount to do with universal access to healthcare without financial barriers, it's important to note that our country has a particular problem with income inequality, racism, access to firearms, inattention to health and safety, education, or support for children and families, to name a few, which undoubtedly also contribute to us dying early. But the lack of access to quality care is a major contributor. So how is our access to that care? Much of our care is controlled by corporations and venture capitalists who dictate what's covered and what it costs. Most other wealthy countries have a government finance system where profit is not a motivating factor. And we've been told to fear that a government finance system like Canada would compromise care. But Americans are 9% less likely than Canadians to receive treatment for chronic disease, are at twice the risk of long waits when needing care for breast or colon cancer, and at more than twice the risk of dying while waiting for an organ transplant. Again, things are so expensive because our system is designed to extract the maximum amount of money from the public. With little price regulation, our drug costs average almost 4 times that of other similar countries. Hospitals are regarded as businesses like any other. Patients, doctors, nurses, and other staff are treated as cogs in a machine a machine that prioritizes profits, not patients. And this has contributed to an exodus of healthcare workers due to increasing work stresses and inadequate employer support. Also, we have absurd administrative costs. Compare that to Canada, where the billing process is much simpler because there's only one payer, the government, and everyone has the same coverage. A US hospital requires up to 100 times as many billing clerks as a Canadian hospital of the same size. We spend more on healthcare administration alone than the entire US defense budget. We have also an epidemic of underinsurance, increasing deductibles, copays that mean that little is covered except an expensive catastrophe. Out-of-pocket spending for healthcare is out of control and will continue if left unchecked. All this has put 41% of adults into medical debt. 2/3 of all bankruptcies in this country are due to inability to pay medical bills. And most of the people who went through bankruptcy actually had health insurance, yet because of high deductibles or other poor coverage, had insurmountable out-of-pocket expenses. And Black and Latinx folks struggle the hardest with medical bills. And for the elderly, the cost of care is astronomical, much more than in other countries. And we tend to think that elderly people or those on disability have little in the way of financial barriers to care, but Medicare is not free. A healthy 65-year-old retiring today, if they live well into their 80s, can expect to pay $300,000 to $400,000 in out-of-pocket expenses or premiums. Out-of-pocket costs and things that are not covered by Medicare, like dental care, eyeglasses, hearing aids, and long-term care. And we're all aware of how the cost of housing increases poverty, but much less aware of how the cost of healthcare strips wealth from the poor and working people. Even with public insurance support for many, the poor still spend 1/3 of their income on out-of-pocket medical costs. We ration healthcare by making it unaffordable for many. And this country has unacceptable racial and income disparities that are widened by our health system. People of color are less likely to be insured, as well as underinsured, receive less care, as well as lesser quality care, and face increased barriers when they seek care. That results in less trust of their care, and people of color face the grind of social oppression, the stress, trauma, and environmental toxicity that comes with it. The less money and power a family has, the more the health burden, the more the financial burden, and the more the injustice. But the gaps are not just about wealth. Rich Black women in California and their babies are more likely to die in childbirth than poor white women. As Elizabeth Wilkerson in her book Caste has written, success, health, and education don't protect against the ravages of caste. The system charges immigrants more taxes, premiums, and out-of-pocket expenses than they receive in healthcare services. Compare that to the US-born, who use more in services than they pay for. And because of this, immigrants, in fact, subsidize healthcare in the US-born. And undocumented immigrants alone subsidize healthcare of the US-born to the tune of $52 billion a year. Those of us who live in rural areas are further burdened by the system. Rural Americans have less access to doctors and dentists, suffer worse health outcomes, have longer drives. Premiums for the Obamacare Marketplace Silver plan average 40% higher in rural areas. Hundreds of rural hospitals have closed and many more at risk of closure. And even those that remain open, the closure of maternity and pediatric units in rural hospitals add to the inequity not because of our inability to do better, but because it's not profitable given our current system of reimbursement. And this has created maternity and pediatric care deserts where women are 3 times as likely to die in pregnancy and the critical year afterwards. Gender inequity is also pronounced in our system. Women and members of the LGBTQ community experience lower rates of being insured, increased barriers to care, greater out-of-pocket costs, and more trouble paying for those costs. And women who divorce are more likely to lose coverage than a male partner and less likely to be able to regain that coverage. America is one of the few countries that ties health insurance to employment. Currently, half of us get coverage through employers. But it's a folly to tie insurance to employment. And that was made clear in the pandemic, when 40 million Americans lost their jobs, which meant that many of them lost their insurance, and millions are still without insurance. How many people lost their health coverage during the pandemic in these countries? None, because they didn't link coverage to employment. What do these other countries do that's different from ours? They provide universal coverage. They invest in more primary care and social services. Not only does the government pay the bills, but it regulates prices, allocation of resources, and any private insurance to ensure that healthcare dollars are spent effectively. So what are the potential fixes to our system? There have been many attempts to patch the holes, but they all keep the same inefficient system that drives up administrative costs and keeps the same corporate control over healthcare decisions. While some of these Band-Aid repairs have helped some people, it funneled tens of billions of new government dollars, our money, into the profits of insurance companies. And because of this, our working group strongly believes that we all deserve single-payer healthcare, sometimes referred to as improved and expanded Medicare for all, a single insurance plan that covers everyone. Instead of consumers and insurance companies, government pays the bills. Profit would be removed from the insurance system. Businesses would no longer offer coverage because everyone would automatically have coverage. There'd no longer be any restriction on the choice of providers. There wouldn't be any more out-of-network issues. In fact, there would be no more networks. The focus on health planning would greatly increase and bureaucracy would significantly be reduced. And no longer would corporations be making decisions about what's covered and how care is provided. And like in most industrialized countries, healthcare would be financed progressively, meaning that wealthy would pay more, much higher taxes than working people. Yet Americans have a deep distrust in anything government run. Why is that? Well, our national culture of individualism, independence, consumerism, crucially downplays the importance of community, solidarity, social fabric, and the common good. Well, over the past 4 decades, governments have slashed budgets and privatized basic services. And that had 2 important consequences for public health. First, people are unlikely to trust institutions that do little for them. And second, public health is no longer viewed as a collective endeavor based on mutual obligation. People are conditioned to believe that they're responsible only for themselves. And we see this in the vaccine hesitancy of today. We can debate the causes, but in the case of public health and healthcare, there's plenty of evidence that a system run by the government can offer a huge advantage when it comes to quality, administrative efficiencies, as well as cost savings. Workers currently pay disproportionately higher taxes, but most don't benefit from Medicare or Medicaid during their working lives. Instead, they bear the burden of steadily increasing costs. Having a single-payer system would improve both their health and their finances. The impact on organized labor would also be very dramatic. Currently, contract negotiations focus on maintaining hard-won health benefits, distracting from efforts to improve working conditions, wages, or pension plans. And you no longer lose coverage if you switch or lose your job or get too sick to work. Right now, 1 in 6 workers in this country stay in an unwanted job just to maintain their health benefits. What about business? For all but the largest businesses, their cost to fund a single-payer system would be less than what they're currently laying out for employee and retiree healthcare. Single-payer would also be a boon for local governments, public agencies, and nonprofits, since they'd no longer have to finance the health insurance coverage of those employees or retirees. To use the county of Sonoma as an example, almost $87 million that's now spent annually on health insurance would be freed up, and much of that money could be redirected to services, wages, and benefits. And it would also transform the way we fund hospitals now, which punishes small community hospitals and those who care for a great share of and underinsured. But rather, it would be financed by annual global budgets based on regional and community health needs, kind of like we fund the fire departments. There are a variety of proposals for how this could be structured, financed, or rolled out. And recently, Medicare for All proposals in Congress cover dramatically more than any current public or private coverage. Hospital, clinic, dentistry, vision, hearing, mental health, all reproductive care, including abortion, medications, and long-term care would all be covered. It would provide all who live in this country, citizens, immigrants, whether documented or not, with portable, lifetime coverage. Free choice of doctor or hospital, no restrictions. It would eliminate all patient cost sharing, no copays, no premiums, no deductibles. And implementing the Medicare for All Act in the federal level would increase the income of the poor by 29% because the burden of out-of-pocket expenses would be eliminated. It would be the biggest anti-poverty program in generations. We have about 41.5 million poor folks in this country today by government measures. If Medicare for All was implemented, 8 million would automatically rise above the poverty line. Working families would no longer struggle to cover the costs of healthcare. It would be universal and guaranteed. And it's important to mention that there's also a strong effort not to wait for the federal government to move forward in a plan to guarantee healthcare for all. The California Nurses Association is spearheading a plan called CalCare. And in California, we're big enough to implement a single-payer system for all residents of the state that would look very much like the federal proposals. Whether it's developed first on a federal or a state level, it's important to ask, how can we afford a system that so generously covers everyone with no premiums and no out-of-pocket expenses? What would it cost, and how could we pay for it all? Currently, we pay $2 trillion in taxes to fund our Medicare, Medicaid, VA, Indian Health, and other similar programs. We need to find $1 trillion more to fund this new system. Where could the money come from? Well, let's back up a minute to understand where the money should come from. In the 1950s, the tax rate on those with the highest incomes was on average 81% in the United States. And the rate applied to the highest inherited estates was 74%. Clearly, these taxes on the rich didn't destroy American capitalism. It was a time of great economic growth. Things were more egalitarian and productive. But since then, the base tax rate for the wealthiest has been lowered so that it's below that of even the poorest Americans. increasing taxes on the wealthiest to pay for their fair share, to pay a fair share, even just a portion of what they paid in the 1950s would more than pay for Medicare for all. All current proposals, including proposals for implementation first statewide in California, would find money would be gathered through taxes where the wealthy and big businesses would pay more. Wealthy being those making over about $300,000 to $400,000 a year. Working people and mid-sized businesses would pay less, and the poor and middle and very small businesses would pay nothing. According to a study that was commissioned by the governor's Commission on Universal Access, Universal Financing, excuse me, without dramatic change, healthcare costs in California alone would increase 30% in the next decade. That's an increase of $158 billion over the next 9 years. However, if we were to guarantee healthcare for all by developing a single payer system, that governor's commission estimated that we would instead save $500 billion in the next decade. So what would it look like? What would this look like for families? Currently, the average family of four with job-based health coverage pays almost $9,000 in premiums, out-of-pocket costs, and taxes, while the average employer pays almost $13,000 for that family. If you have a family of four and an income of $50,000 a year, under the Sanders financing plan, you would save 90% of what you're paying now, and your employer would save 70%. If your family earned $100,000 a year, you'd pay 2/3 of what you're paying now, and your employer would save more than 42%. Certainly, there would be new costs in blue, raising reimbursement rates to providers, providing expanded coverage, particularly the expensive expansion of home care, skilled care, and dental coverage. These additional costs, however, would be overshadowed by the new savings in red, resulting from reducing bloated profits and costs of administration, as well as increased regulation of drugs and devices. But since we're drastically overpaying currently, almost all economists agree that we would collectively save hundreds of billions of dollars each year. And it's clear that cost is not a barrier to its adoption. And most importantly, it's estimated that establishing in our country improved and expanded Medicare for all on its own would save over 68,000 lives a year. And the National Academy of Sciences estimated that during 2020, during the COVID pandemic, that figure would have been $212,000 lives saved in a year if we had guaranteed healthcare for all. And those who would not have died. Our priorities are profoundly skewed. A nurse who mistakenly kills one patient gets 8 years in prison. Our insurance gaps kill tens of thousands a year, and nobody's indicted. Surveys show that people aren't happy with our current healthcare system. The overwhelming majority of Californians believe we should have a government-run system instead of a GoFundMe's for life-saving interventions. Transition will be challenging. Some in power claim that trying to dismantle the existing system and replacing it with an entirely new one would be both a non-starter politically and too disruptive to the economy. The same argument was used in an effort to maintain slavery, fight child labor laws, Social Security, and Medicare. But disrupting a healthcare economy that's not working and replacing it with one that would is precisely what we should want to do. We've been lulled into believing that the current way of healthcare is the way it has to be. The system spends too much on care that delivers too little benefit to too few people. It puts many of us in debt, perpetuates inequality, racism, inefficiency, and it results in deaths that our rich country should have prevented. Dignity, fairness, and justice are what we're fighting for. So I'm going to leave it at that. We think this is a key struggle for our time and would encourage you to join us if you consider either checking out our monthly meetings on Zoom or are part of a group that would consider having a workshop, presentation, or dialogue with us. And please, if you would like, there are clipboards out if you would like to provide information so that we can keep you abreast. And with that, we're a small group and I'd love to have a discussion, and I'm going to move down off the stage for that. Comments, questions, anything?
It's on. Okay, so we can move you off the stage, but if you want the audio recording of the discussion, I'll just give you the travel mic and you can facilitate Q&A. And just a reminder for everyone in the audience, we have these evaluation forms that we rely on to get funding for the event, get feedback on speakers. So those are on your seat and the sign-up sheet is coming around. All right, thank you, Terry.
It feels silly of me to sit up there for this crowd. This one. Okay. Any comments? I mean, it's a lot of information and it's controversial, and much of it you probably never, you've heard before. There's been increased discussion about this, and ever since, especially Bernie Sanders brought it to the fore nationally. But there's increased discussion about that in a serious way in the state of California.
I'll ask a question while everyone gets theirs ready. What do you think about what's going on at the Supreme Court and renewed challenges to bring this to the Supreme Court of the United States, challenging things like Obamacare and this issue generally, as opposed to what's happening in California? I think let's get the discussion going there, and then everyone else can ask their questions.
Well, the Supreme Court has become increasingly politicized, as we all know. The threats from the Supreme Court, as well as the lack of ability to take any action on the federal level, really makes a very strong case for doing this first on a statewide basis. As a state that's as large as we are, we can clearly do that. The economists have run the numbers. The bills have been are present and currently in the state to do this. The difficulty is not actually getting it passed in the legislature in the state. We just have to do our education in advance, because given the fact that it would increase the taxes on a local level, even though remove premiums, remove all out-of-pocket expenses, it would increase taxes, and I mentioned, for some, much less so for most people than they pay in premiums or deductibles, or don't get because their employer can't pay them a higher wage because the employer is paying so much in terms of insurance. There's an advantage of doing this on the state level, and because the Supreme Court and the conservatives have said we want more decisions made on the state level, it really increases our ability to really sort of take them up on that and make those changes. And as with many things, California is oftentimes the ahead of the pack, and it gets slowly implemented throughout the country. And then hopefully, eventually, it should be a national effort, because the problem is you cross state lines, you move out of state, you lose your coverage. It doesn't make any sense in the long run. However, for people who desperately need healthcare and live in this country, live in this state, it certainly would provide a tremendous improvement of what we have now.
And can you talk about California? What would improve over covered California, the sort of interim plan that people fought for?
Well, again, covered California, those and Obamacare has been an advantages. Medicare expansion has been an advantage for some, but each of those have big gaps. One, with all of those financing systems, a significant portion of it goes to corporate profits, which is lost to care, which would not be the case with a single payer system, because the insurance piece would be removed. So just to clarify, I have Kaiser coverage. It wouldn't eliminate Kaiser.
Some nods in the audience. A lot of
Yeah.
us that work for
It
Sonoma
doesn't-
do.
It doesn't eliminate Kaiser. It would eliminate the insurance portion of Kaiser. The hospitals would still be the same. You could still go to the same doctor. You'd still have the same clinic. Okay. But you could choose, if you had a condition that you wanted a second opinion on, go to UCSF or some other hospital, and you could do that without getting authorization from Kaiser. So it is a more open system than what exists now. Go ahead.
Do you already have some of these bills? Like, are any of these coming up to be voted on anytime soon, or?
In the there is a bill in the Senate that Bernie Sanders introduced. There is a bill in the House of Representatives that was presented or will be presented by Representative Jayapal from Seattle. We don't expect those to pass anytime soon, but each time we do that, we push even further. For instance, the House of Representatives bill, this last time had 120 representatives who sponsored the bill. So it is not an insignificant number. But again, knowing what we know in the politics of the government right now and in the US government, we're just sort of taking baby steps and not. On the other hand, in the state of California, there are two bills that have been presented. One is the CalCare bill that I mentioned that was introduced by the California Nurses Association in the Assembly. And that is a 2-year bill, which means that there's negotiations on the first year as to exactly what the details of the bill would be. And then there will be votes in the second year. Each year that gets presented, it gets more support. I don't think this will happen in the next year or two. It's a step-by-step process. It may take 10 years, it may even take 15 years. But considering the fact that all of these tens of thousands of people are dying each year and other people are going in debt, and the suffering and the impact on business as well is tremendous. So the sooner we can get the change happening, the better. I mean, again, people think that this is pie in the sky, but almost every other country, a wealthy country in the world, has figured this out. And yet we refuse to take the cue. So it's just a matter of time before it happens. It's just we want it to happen in our lifetime.
Can I do a follow-up on that with what you presented about COVID and the comparative international responses? Do you think that the past pandemic, and now we know we're likely to have future pandemics, is shaping this discussion? And if so, how?
Well, again, the past pandemic, or it's still a current pandemic, I guess it's a current epidemic, past pandemic, really showed several things. As I mentioned, it shows that linking insurance to the job makes no sense. Classic example was the Unite Here union that represented culinary workers and housekeepers in Las Vegas, encouraged their members to vote against Bernie Sanders and to vote for Clinton in the presidential primaries, because they were concerned that a guaranteed health care for all bill would somehow dilute the ability of them to provide and to continue to be proud of the clinics and the health benefits that they were able to gather for their employees. The members of the union ended up voting primarily for Bernie Sanders, regardless of the recommendation of the leaders. But what happened was And they had a very nice system for their employees, and one that they were very proud of, rightfully so, with dedicated clinics, which could remain, by the way, with single payer. But they would feel like, oh, what are we doing as a union if we're not fighting and showing how proud we are about our clinics? But then what happened? Then the pandemic happened. 70% of those union members lost their jobs. And with that, they lost their health insurance. So it ended up being a very blatant example of where, well-intentioned liberal unions arguing against this kind of change because fearful that it was going to take away their political power, it completely backfired on them. So, the other thing about the pandemic is that our public health system was woefully inadequate, poorly funded, not well coordinated, didn't have a lot of political power, and there was not, no too little foresight, and it was just a chaotic response. We could have saved many, many lives. Again, probably at least a quarter of the people who died from the pandemic in this country would likely not have died in a system that with a guaranteed coverage. I mean, people hesitated to go to the doctor, whether they were promised to have it paid for or not. They didn't trust that. They didn't go till it was too late. It was just a horrible situation, and we really need a situation. I don't know how many of you are familiar with the systems for healthcare in other countries. For instance, in Canada, or England. England, if you even as a visitor get hit by a car in London and are taken by ambulance to a hospital, your bill for the ambulance ride, for the hospitalization, for the surgery, for the follow-up, for the outpatient clinics to follow that is zero, even as a visitor. They think that we are nuts. They really think we are nuts, and they just don't understand it. When we explain the details of the confusion and the chaos that occurs, I mean, just the other example of, in a hospital, a 900-bed hospital in Montreal, they have one billing clerk to handle paperwork for insurance. Okay, because they only have one insurer and a standard way to file that claim. In a same size hospital in a city in the United States, they need an average of 100 billing clerks to do the exact same work. The folks in Canada who were involved in those systems, they scratch their head and say, what? What are they thinking? And why aren't they doing something about it? And who's paying for it? We're all paying for it, whether we pay for it through our own premiums and deductibles, or whether we pay it through it because our employer can't give us the money we deserve because the employer is paying an arm and a leg for their health insurance.
Good to see you, Terry.
Hi there.
So can you explain what Healthcare for All Working Group does, what your role is?
Yes.
Okay, and then as far as outreach and education, what's that look like?
Well, we do these kinds of events frequently. We work with unions, with religious organizations, with student groups, with social justice groups a lot to really advocate around these issues. We do work politically too around legislature. Let's take it a perfect example. I happen to live in Sebastopol, but in the far north end of Sebastopol, which is Assembly District 2, which northern Santa Rosa up north to the Oregon border. is Assembly District 2. And the assemblyman there is Jim Wood. And he is a dentist, and he is the chair of the Assembly Health Committee. And he historically has been an opponent of single payer, and he's been a proponent of kind of more half steps to improve things, but things that really don't have huge, major overall impact on improving things. And we've been working with him for years. He knows us well. We've been meeting with him. We've been challenging him in a positive way, but challenging him nonetheless on this issue. And he, as the chair of the Assembly Health Committee, has a lot of power around this issue around moving bills or not moving bills or moving the discussion to the Assembly floor. We decided a couple of years ago, when the last single payer bill was present in the Assembly, to create an open letter. And we met with 124 community leaders and organizations in his assembly district, which is a lot of folks for a pretty rural assembly district. We sent that letter to him, and within 2 weeks, he officially reversed his position, and now is an official supporter of the single payer system. Now, we're going to have to still hold him accountable if our work is not done, but that's the kind of work we've been busy doing. In addition, we take another example. We're doing a talk at the We the Future JC conference in the Petaluma campus later this month. And we are training high school students from the Healdsburg High School Democratic Socialist Club. I didn't have a Democratic Socialist Club when I was in high school, but anyway, there is one in Healdsburg, and they are going to run the workshop on single payer. So we work with students, we work with youth, we work with people of color, we work with unions, and we work with legislators. So we do what we can. We're small, but very, very present.
So say this single payer passes and we get it established. Will that cover all the current debt, like medical debt that they have now, or is that just starting now? They don't incur any new debt and they just have to pay off the old debt?
Honestly, it does not address old debt. There are bills that can address and have, address those kind of issues, like surprise medical bills and other things that we support that sort of eliminate those chances for people to incur debt. But it's such a complicated process that we really kind of look at from here forward. But I think there needs to be other legislation to sort of help with that. I didn't finish my thought about well, I forgot it now. I'm sorry. I'll get back to it. But other questions, comments? I know people struggle with this. And those of you who are students, most of you don't have to struggle with this now. But once you're out of school, once you turn 26, it's a rude experience to be faced with this. It's a phenomenal issue, and we just got to get our act together on it.
Thank you so much, Terry. Do you want to
Thank you.
give one last round of applause and then I'll make an announcement about
Thank
the
you.
rest of the days?
And anybody who wants to, either with these clipboards that are around, or at the table right outside the door, if you want to just, at the very least, know what we're up to and get a monthly email about our meetings, about latest legislation, about interesting articles and studies that have come out. It's really, it's really fun to be involved.
Thank
very
you.
much.
And just last announcement, two last announcement, fill out the evaluation form, and you can do that online or in the hard copy, so we can keep getting feedback and paying speakers. And then we are going to transition our next panels in half an hour, but it's on related issues, health and safety issues on campus. So we're going to hear about CAPS, mental health services instead of COPS. And we do have a continuation of that discussion and union representative for that. We then want to make sure that you get your tickets if you want to come to the Ijoma Olu talk tonight. We also have a reception with food and drink before. So out on the table outside are those. And one more related talk, our California Faculty Association Union is going to be coming tomorrow 2:30 to 5 and doing a training. So thanks so much.